The actual article in here, the chapter in here, is written by Jerry Hoffman, and for those of you who know him, he's got extreme skepticism about the place of thrombolysis for stroke. I think there's probably no area in emergency medicine where there's more tension and angst between believers and non-believers, and the issues of pharmaceutical sponsorship and all of that kind of thing comes to a head more here than for just about anything else. For this particular section, there's actually only 5 articles to go over. There's actually really 6. There's only 5 in here. So I think we do have some time to spend on some of these issues and working through them. I think that the fundamental question that really comes up with stroke, the one to which we do not know the answer, is restoring blood flow to the brain that has had some impairment of blood flow a good thing or not? Because it's clearly a mixed bag because of the bleeding issue and because of the swelling issue. We don't see that with the heart. How many here have seen a hemorrhagic myocardial infarction? Doesn't happen. Cut off the blood flow to your leg for 3, 6, 8, 12 hours and restore the blood flow. The worst you get is some swelling, or maybe the tissue doesn't come back, but you don't bleed. In fact, the brain bleeds even without an insult. When we give thrombolysis for a heart attack, the brain bleeds. We don't see bleeding into your biceps. We don't see bleeding into the lung tissue. What is it about the brain tissue or the blood vessels that makes that happen? That, to me, is much more fundamental than a lot of this other stuff, and it speaks to the issue of how much of a two-edged sword is this. So let's kind of work through this. What is really new in terms of studies on stroke? Well, there's hundreds of articles about stroke, but none controlled. These are the few, quote, controlled studies. So let's kind of work through them. How many here have heard of ECAS-3, the European Stroke Trial 3, that supposedly says there's a window for thrombolysis out to 4.5 hours? Well, I'll let you read what it is Jerry had to say about this, but I want to work through a couple of the issues here, just because you actually need the articles to actually look at some of these things. They said, first of all, the authors of this study, and this was a sponsored study. So if you actually look at the article here, there are, I don't know, 13 or so authors. Every single one, except for one, is either employed by Boehringer Ingelheim or does work in consulting for them. I'll just kind of read to you from the sponsorship thing here. Dr. Hack reports receiving consulting, advisory board, and lecture fees from a whole bunch, including Boehringer Ingelheim, and grant support from them. Bozeman receives consulting and lecture from these. Davalos consulting and lecture fees from Boehringer Ingelheim. Dr. Cass consulting and lecture fees. LaRue consulting, Lees from consulting Boehringer Ingelheim. Grant support from Boehringer Ingelheim. Every single one, grant support, lecture fees, or on the advisory board of the company that sponsored the thing. And then when you look at, they say it was designed by the ECAS-3 people, the European study investigators. Steering committee chairman, Dr. Hack. He's the one who has all the other stuff listed in there. All the others on this, on the steering committee, except for one, are employees or work for Boehringer Ingelheim. Data and safety monitoring, every one of these basically has some connection to that. Of the then 133 investigators, this is one of these multi-center trials where 133 investigators are going to put in data to this thing. So you have basically not just a funded study by the maker of the drug, but every aspect to this controlled. Let me just kind of take a little side note about how when you design a study or want to design a study, how knowing some of the issues helps you in determining what kind of outcome you might like to see. I've often said I'm from Michigan, so one of our big issues is who's better in sports, Michigan or Ohio State? And so, well, I'll say Michigan's better. Look at it. Let's just include the big sports, football, basketball, baseball, and track. Well, how would you combine those? I mean, Do you do it by total points scored in the year? Well, look at how that would favor your basketball team. 100 points in a game. Well, maybe throw in hockey. Well, geez, 3 points in a game, that wouldn't get you much. So maybe you need some way to balance those out. And for those of you who follow this from the States, you would realize this year we would not include football in this, in this thing. So maybe we take a year off from that kind of stuff. So knowing how you want to put things together, you can get to your pre-specified endpoint kind of thing when you control all of the aspects of a study design. So a couple of things that they did here. They then took these people, and they got some modest benefit in the ways in which they looked at these things. They excluded bad strokes. They excluded people with both diabetes and a prior stroke, and then said that if they gave it out to 3.5 hours, they seemed to do a little bit better. And the measures that they use are the usual reasonable kind of measures, disability at 90 days. Actually, the abstract in here, I'm getting some feedback here, aren't I? The abstract in here says there was no pre-specified outcome endpoint. That's not actually true. There was a pre-specified outpoint. It was disability at 90 days. That's the standard one for stroke kinds of things. So who did they exclude from this kind of study? In the people who were supposed to get the drug, 43 were excluded. Protocol violations, didn't get the drug, uncontrolled hypertension, didn't meet the age criteria, didn't meet CT criteria. They received treatment outside of that window, or they had other reasons. And there were about 48 in the group that was not supposed to get the drug. Some of those, they excluded them because they didn't get the drug. Well, they didn't get the placebo, so that kind of stuff. They never said, well, how about if we just roll all those that didn't get it into the didn't get it category? We don't know how that would have worked out. They obviously know. We're not told that. So they excluded protocol violations in this. Again, if you know what happened to the people with protocol violations, you decide who gets it and who doesn't. 10 were lost to follow-up. Bunch of things that were sort of funny with it. But I think if you look at this, this is basically a drug company paid for, sponsored trial, and maybe it extends the window for this study. And then, as Jerry comments in here, you have to look at the Atlanta study, which did a very similar thing and found increased mortality, trial stopped early, no use for it. They even say at the end of this one that this is not approved for use in the US in this extended time window. How many here are giving this stuff in the extended time window? Nobody. Very interesting. All right. So how about a community effectiveness study? This now gets to the so-called SITS most and SITS ISTR studies done in Europe. One of the deals done with the European community to approve thrombolysis for stroke was they said, well, you need to have an ongoing registry so we see what happens with these folks down the road. We understand what the studies show. There's 1 or 2 positive, many negative, but if we're going to approve this, we want to know what's happening with these people down the road, so that's good. And we want to know what happens when it comes beyond the 3-hour window. What's going on with those people? I'm not sure why they asked that, because it wasn't supposed to go beyond the 3-hour window, but they asked that. So the first of these was so-called the SITS most, which was published in Lancet in 2007. And so when you look at this trial, what they did is they took a registry, and people from all over Europe and actually other countries could submit patients to the registry over a website, and then they kind of validated what it was they had, that sort of thing. And then the SITS most committee looked at this to decide what was going on with these patients. And so, again, when you look at the faculty that are on this and what their conflict of interest stuff was, most were all the same as the previous ones that I mentioned to you. Worked for Boehringer Ingelheim, that sort of thing. So a couple of things happen with this. They first of all, they don't know exactly all the people that got the drug. You had to voluntarily submit that. So they even admit, we don't really exactly know who all got the drug with this. which is one of the things that happened. So how many didn't get it, they don't know. And then they had outcomes. They want to know what happened to these people down the road. Well, all the other studies, if you looked at, are 90-day outcome, you know, how they are at 90 days on a disability scale. Here, they could get a phone call from the patient. They could get a phone call from their doctor. They could have somebody fill out a data form on it. So endpoints there are a little mushier than we might see otherwise. So that's the nature of registry data. You can't tell that everybody's in the registry, and unless you organize, go out and do the same follow-up you would do with others, you really don't know how well they're doing, other than this kind of thing. Then what they did, so I consider those the unfixable problems with registry data. That's the way it goes when you do a registry. The fixable problems with it were that they actually excluded everybody who had a severe stroke from this. So if they had a severe stroke and they got the treatment, we don't know how they did, so we don't really know how to compare this group to the original thrombolytic trials who didn't exclude these folks. So that was one that would actually be fixable. So the most you could conclude from this is those that have a mild to moderate stroke, how they did compared to those who have all comers in the other trials, and they said they did comparably. And they excluded all protocol violations. So the original intent of this was to see how are people doing in the community. You know, how well does this perform in a community, not in a more maybe controlled either academic or research environment. But then they threw out all the protocol violations, which in every other study is where a lot of the problems occurred. So not really community-based on that. Actually, let me go back to one of the first study that I mentioned, because there's one point here where I wanted to mention another spin that you see on it. If you actually look at the article and you look at the summary, what they say was the incidence of intracranial hemorrhage was higher with alteplase than placebo, okay? 27% versus 17%. Or for symptomatic intracranial hemorrhage, 2.4% versus 0.2%. It's very interesting that we now consider bleeding in the brain potentially no big deal if certain things don't apply. So that number, 2.4%, symptomatic intracranial hemorrhage. For those who follow this literature, does that sound high or low in the treated group? It's low. Right, what was it in NINS, 6%? They say, huh, not so bad. It is worse when you get the drug than when you don't get the drug. However, if that's all you ever read, you won't understand that what they did was they redefined symptomatic intracranial hemorrhage. And they actually go through this in their study. They say symptomatic intracranial hemorrhage from the standpoint of ECAS-3 was, let me get this straight here, any hemorrhage with a neurologic deterioration is indicated by an NIHSS score that was higher by 4 points or more than your worst score previous to that, or a hemorrhage leading to death. When they actually went back and did it based on the NINS criteria, they then had almost 8% intracranial hemorrhage, worse than the NINS trial. But they redefined it for this one, and then they had ECAS-2 definition. So it was 2.4 in that definition. The ECAS-2 definition, they switched again, and you didn't have to have, I think they didn't include the deaths. Then it was 5.3% more. And then there's SITS most, which is the one that I've done here, as yet another different definition. So if you really only read the abstract, you think, oh, not so bad. If you go into the details, there's a few more things going on with it. So those are the things that I consider sort of fixable and unfixable things. And I think if you are in charge of this, it'd be nice to have the fixable stuff. So SITS ISTR is the next one, and that is in the community, when people are getting thrombolysis between 3 and 4.5 hours, what's happening to them? Well, first of all, why should they be getting it between 3 and 4.5 hours? Because it's not approved for that use. But they decided, well, some people are going to get it there, so let's just, based on our regulations here, try to figure out what happens to those people. So this is, again, an observational study, and a couple of things happen with it that are sort of strange. They did modified Rankin score, that kind of stuff. And they said the study protocol, oh, I'm sorry, I have to back up to the SITS most one. They said in that the, hang on, I'm confusing which study here. So this is, the SITS trial was done in close collaboration with Boehringer Ingelheim and SITS and EMEA. But everything was done by them. In the next one, they said, well, we just had our own way of designing the study protocol. But everybody in the second one was in the first one, which was designed by Boehringer Ingelheim. So I don't know why they thought that somehow these were different. Everybody on the committee here was either employed by or worked for, or most of them worked for Boehringer Ingelheim. So how did they do? They did, in their words, not too bad. Oh yeah, so in SITS ISTR, the group included all participants in the previous SITS most. But in their write-up, they said, the sponsors of the study had no role in the study design, data collection, data analysis, data interpretation, or writing of the report. But in the previous one, all of their folks did all that, and this is just a subset of that group. So I don't know how they had that, how they were able to say that. Okay, so they're talking about their limitations. In a large multinational, multi-center registry study aimed at collecting data indicative in routine practice, perceptual and technical differences between centers are a possibility that could have affected the assessment of intracranial hemorrhage, which was self-reported by local investigators. Furthermore, the potential bias of patient selection for treatment beyond 3.5 hours is another consideration. So what they're saying is they really have no control over that. So they've now said that this done in the community is not so bad, but again, all the same limitations apply to the first one that I did. Next set of issues comes up here. What's happening with aggressive blood pressure lowering? You know, one of the exclusion criteria is that if you have significantly high blood pressure, you're not supposed to give the drug, unless you can lower it a little bit. And so how much should you have to lower it and that sort of thing? So let me again diverge a little bit to the two-edged sword of elevated blood pressure with stroke. You realize once you have loss of autoregulation, then blood flow, cerebral blood flow is pressure dependent. Okay? So cerebral autoregulation means this. If I take this person here and slit their aorta and their blood pressure goes down, you know, systolic 100, 90, 80, 70, 60, what happens with that is that the brain blood vessels dilate so that enough blood is getting to the brain so that it's the last thing to go. So you don't pass out with that kind of stuff. Because well before that, you shut down blood flow to your kidneys, your GI tract, all that kind of stuff. You're preserving that central blood flow because that's what's going to keep you alive to help yourself or get rid of whatever problem is going on. So that's cerebral autoregulation. And it works down to pressure in the 50s, and then there's not enough perfusion pressure and you pass out and other bad things happen. When you've had an insult to the brain, you lose cerebral blood flow regulation. The other side of autoregulation, by the way, is if you pump up the blood pressure, 180, 200, 250, the blood vessels vasoconstrict to keep the blood flow just where it needs to be. Okay? That part is lost in a variety of insults. So now when you have an area of brain that doesn't have much blood flowing to it and it doesn't have autoregulation, you drop the blood pressure, you lose flow to those areas. Raise the blood pressure, you get more flow to those areas. On the other hand, raised blood pressure and blood flow to that area may not be good. You may bleed more. So it's a definite two-edged sword here. It's damned if you do and damned if you don't. So we don't really know that. We actually know with some strokes, the thing you don't want to do is you don't want to drop their blood pressure. We probably know now that that's worse than dropping it. Certainly dropping it acutely seems to be really bad. But anyway, they took a bunch of patients. This is a chart review study from the University of Texas. They had 178 patients treated with TPA within 3 hours of onset, and 50 had to be treated with either labetalol or nicardipine for elevated blood pressure. And so what they said was, well, is there a difference between having aggressive blood pressure lowering or just kind of blood pressure lowering? And they defined that, I find this somewhat artificial, is if you just got labetalol, that was lowering your blood pressure. If you had to add nicardipine, that was aggressive, okay? Or if you just got nicardipine, that was aggressive. Not sure why that is, but that was their definition. And then they said, is there a difference between those that got aggressive versus just regular blood pressure in terms of their outcome? No, wasn't much difference. How did they do compared to those people who actually didn't get aggressive blood pressure lowering or any blood pressure lowering? And what they said in their conclusions was there was no significant difference. Okay? But then if you actually look at the article, okay, so intracranial hemorrhage in the standard one, 19%, 20.8 in the aggressive. Symptomatic hemorrhage, 3.8 versus 4.2. Neurologic deterioration, 11.5 versus 25%. Good outcome, 69% versus 79%. In-hospital deaths, 7.7% versus 12.5%. So by every measure, it was worse. Well, why did they conclude that it wasn't statistically significant? 50 patients in the study. Underpowered to decide that. So again, if you want to design a study that shows there's no difference, just don't put a whole lot of people in it when you want to have your comparator there. So, and then how did they compare with those who didn't get any drug who had really high blood pressure? They say, oh, we don't really know that. We don't know who didn't get it because they didn't have aggressive blood pressure lowering. So again, I think they would like us to conclude that it's okay to aggressive, not only, so they go from it's not significantly different, there may be no difference between these, to you should do it. Again, I don't know that you can conclude you should do it from something underpowered to know if that's the case. Then the last one here is something that is being touted as the next way to go, and that is the difference between giving a reperfusion therapy to somebody who has brain at risk but that hasn't yet infarcted. This is a classic teaching in stroke stuff where you have a central core, it's infarcted tissue, it's too late, goodbye, you can't do anything about that. And then there's this penumbra of tissue around it that it's not getting quite enough blood, but it's not dead yet. So if you could restore blood flow to that, it should be good. Kind of makes sense in that way. And so how do you find that kind of brain out there? Well, one of the ways is this so-called MRI mismatch between diffusion and perfusion. What happens immediately with dead tissue is you have an abnormality of diffusion of water molecules goes into that area. And what happens with ischemic brain is that it doesn't have that. But it does have less perfusion. So you can use the MRI signal to see what part of the brain has some perfusion that's abnormal, but not yet diffusion abnormality, and create a ratio there. Now the trouble with this is nobody knows what that ratio should be. In this actual study, they had 8 different ways that they calculated that. And nobody agreed. You showed it to a bunch of different radiologists. None of them agree exactly which category it fell into. So that they did that, and then they gave patients thrombolysis, and then went back and looked which ones had this mismatch. Well, for 7 out of the 8, they couldn't find any difference. For the 8th, they said, okay, here's one where there's a difference in outcome. The difference in outcome was only if they reperfused. Not all comers. So in the all comers, it was no different. You couldn't predict ahead of time who would reperfuse, but of those who did reperfuse, they did a lot better. I don't know, an odds ratio of like 25 or something like that. So from this, they conclude this is a promising technology. So I think what you conclude from it is prospectively, we have no idea who to apply this to. We first of all don't know which of these criteria for mismatch works, and then even if we could do that, we don't know which ones would actually benefit because we don't know who's going to reperfuse. And obviously some of those who reperfused based on other criteria didn't do as well. This goes back to my talk about how restoring blood flow is not necessarily good in that. And then the last one here, it's called damned if you do, damned if you don't. This is about litigation for the giving of or not giving of the thrombolytic for stroke, and they indicate that there's more cases for those who didn't give it than for those who did, but there are cases on both sides. If this Westlaw thing actually picks out all these cases, and I don't know how good a registry that is, but this sounds like this is a big issue. Everybody's, oh my God, there's all these cases of people either giving it or not giving it, and it's this medical legal quagmire, and I'm going to be damned if I do and damned if I don't. Well, if you actually look at the cases, there were 28 cases in 5 years. Only half of them were emergency physicians actually defendants in it, involving other specialists. And in those, there was no neurologist involved in half of those. So what that says that there's 7 cases in 5 years in emergency medicine that had no neurologist involved with it. So I don't view that as a big number. I just don't know how well this Westlaw group can pick up everything that ever happens. But be that as it may, that's pretty much all I have to say about that.